Okay, good day. My name is Alberto Miselli. I'm from Caracas, Venezuela, and I want to share with all of you a broader concept, the submergence profile, the intermediate zone when the pink tissue meets the gray issue. I'm from Caracas, Venezuela, in the north of South America, and we start now talking about what happened. What is the implant? What is the implant without biology? If we don't consider the biology, what is an implant? And what is an implant without a prosthetic planning? It's just a screw. And what is the biggest problem that we find in our office every day in our patient who have implant in the mouth? We have perimplantitis. We find a lot of perimplantitis in our patient. This is our enemy. This is a pandemia. Yes, it's a pandemia. Because in this article, it's from Spain, from Rodrigo and Sanz and Cafese, rest in peace, they wrote an article about the 51% of the patients suffer peri-implant disease and 24% have perimplantitis. It means it's a very, very common to see patient suffering some perimplantitis disease. But why? Why we find this problem? What is the risk of perimplantitis? We have a list of many risks of perimplantitis: poor oral hygiene, smoking and alcohol, systemic disease, previous history of periodontitis, previous contamination of implant site, the implant surface, genetic, and occlusal overload. But which mistake we have done all these years? So we are going backstage and we want to see behind the scene what happened in this patient. To find a hard and soft tissue stabilization around the implant, we have many things that we need to know and understand. The first of all, and the most important, are the host. The host we need to know how is the systemic condition of this patient, habits, the factor that produce this problem in the mouth. What happened? In the recent meta-analytical data have suggested that the prevalence of perimplantitis to be 80 or 19% of at patient level, 13% of implant level. But how is the percent of the operator factor? This operated factor depends of many things: drilling, excess of torque, stress of cortical, 3D implant position, not considering the biological width, wide healing abutment, flap, bone and connective tissue regeneration non-stable, flap with pressure during the healing, temporary crown subcritical contour wider than implant diameter, overloading and trauma. But there is many more factors to consider when we decide to place an implant. We need to know that the tissue around the teeth and around the implant are similar, but not equal. Not equal. Because the vascularity and the connective tissue fibers around the teeth or around the abutment or the abutment of the implant and the crown are different. So this is not similar. It's similar or not, but not equal. Sorry. When we see this lamina, we observe that the implant must be crestal bone or subcrestal bone. And this is the difference when we find platform switching or not. And when we decide to place an implant subcrestal, we need to understand what kind of implant we need to place in this area. In the other hand, we need to know that the emergent profile, the tissue around the abutment and the crown, must be healthy without inflammatory cells, and we need to know that the biology in this area is very important. The connective tissue in the bottom is very organized with many connective tissue and collagen fibers type 1, because these fibers are rigid, and the vessel going around the abutment to feed all this area and feed the bone just beneath the connection. In the article of Vela Xavier and Rodriguez Xavier from Borg, Barcelona, they explained that they found many circumferential fibers around the abutment, more than horizontal and parallel fibers. And the tissue, and the capillary vessel run around the abutment like the collagen fibers. We know that the platform switching improve the stabilization of this tissue, and these fibers stay mechanically in a place, creating an emergent profile and biological width. These areas from the platform to the gingiva contour is very important to study and understand. On the other hand, if you are a prosthodontist and you need to create aesthetic result for the patient, a crown over implant is just an illusion, because we can use many materials, aesthetic materials, to create a beautiful crown. But the biology beneath this crown is very important, and we need to understand. Not just a good ceramic, but also a healthy tissue. We need, in order to create aesthetic, pink aesthetic and white aesthetic, we need to know how we can manage this tissue with the temporary crown or with the healing abutment. So the total aesthetic is a terminology to understand that we need to create aesthetic in the white zone and in the pink zone. So I don't want to say I create. No, I just summarize the umbrella concept that is a conjunction of concepts that exist in the world literature about the management of soft tissue and hard tissue seen in the three-dimensional way that allow the preservation of the marginal crestal bone, the gingival architecture, and the aesthetic around the peri-implant supracrestal complex, and the stability through time. But what happened when we receive the patient with the implant in the mouth? For example, with a custom healing abutment, we need to know how much soft tissue we have over the implant platform. We need to know. And this distance is very important to know what we need to know that this tissue over the platform, we are going to create a demergent profile and the new biological width. No matter where is the implant is osseointegrated, then we can move. And if we have less than 3 or 4 millimeters of soft tissue, we know that we are going to lose bone around the implant. In this article, the Stegman and Monge explain what is depend of the position of the implant, what shape we need to create in the abutment or the emergent profile. We have 3 positions: light buccal, centered, and palatal. And it depends, this position, we need to create a special shape to promote more soft tissue in the buccal face. In this draw, we see the implant in the buccal, centered, and palatal. And we need to create more soft tissue. It depends where is the implant. Umbrella concept is a different kind of design, because we know that submergent implant subcrestal are better, depending if we choose the implant with a stable connection. What is a stable connection? A conical connection, conomorph connection. And in this area, we don't have micro movement and pumping effect as Zipprich in their videos show what happened when this abutment receive a coaxial force. The micro movement is not beneficial to the biology stability. So the design of the crown is more gingival, because we need to protect the crestal bone and create more soft tissue in order to fit this crestal bone. So in this picture, we see three zones: a critical contour that Ernesto Lee explained very well, the conditional zone, as Milko Villarroel explained in his articles, and a plague zone control where Nikos Mateos and Ioannis Vergoulis explained very well. This area is very important to protect the invasion of bacteria. So we find many questions in these topics. First of all, is zero bone loss a possibility when placing implant? TOMAS LINKEVIČIUS explained very well. Is subcrestal implant placement the right 3D position? Subcrestal implant placement lost bone? This question has one of the key of the answer of all this problem of the situation, because the platform switching preserve the crestal bone, and the literature talking about the platform switching help to preserve this crestal bone. In this X-rays is 5 years later that the implant received a loading. The implant was placed in a fresh socket. The abutment placed in the same day, and provisional with the loading in the same appointment. We can see the bone grow over the platform, and this is a very zero bone loss. We protect all the implant and abutment connection because this implant has a conical connection, very stable. On other hand, when we decide to planning a restoration, we need to know, first of all, where is the zenith of the gingiva is going to be. After all, we need to know where is the papilla and how much bone we have in this area. After that, we decide the depth of the implant to create the future biological width. This is the position that the implant is going to be, 3 or 4 millimeter depth from the zenith, because the zenith decide all. But what happened with the all patients, all case? We need to fix sometime or improve what we did. And we are going to show you a case, very, very interesting case. Start in 26, and we place the implant in a fresh socket, healing abutment, and we restore the crown very close to the platform implant. 3 years later, we see a remodeling, the bone remodelation, very good, but in the 2011, the patient come to our office because the crown is loosening, okay? And we see bone loss. We decide to extract the crown and modify the subcritical area to reduce the volume of this area in the crown, reduce the volume of the abutment, polish very well, and we decrease the overcontour of the subcritical area. We increase the biological space. We're creating more space for tissue, more vascularity, and stop to bone loss. We observe the tissue is very healthy, and the crown maintain the papilla and the gingival contour very healthy. In these three X-rays from 2011 to 2014, we see we change the shape of the crown, creating a little platform switching, and we observe 2 years later the bone grow and see a healthy cortical around the implant. It means if we create space for tissue, we create health. And we observe that the bone go to the zone, the comfort area, and grow because the bone has space, and the tissue help the bone feeding with the blood supply. So in the all cases, we in our clinic, we take out the crown, remodeling the crown and the abutment, because when you use USLA, the technician places ceramic until the platform implant, because they think that if they protect the gray zone, they protect the aesthetic. But it's not true, because ceramic is not biocompatible. And the metal that we use in the USLA is not biocompatible, because we use chromocobalt or another no precious metal alloy. And we reduce and create a little suture platform in the implant, and we see in many cases that occur a bone stabilization, soft tissue stabilization, and we see that the perimplantitis stop it, okay? But it's just a clinical observation. Okay, when we decide to place an implant, we need to choose what kind of implant we need to use in this case, and where is going to be. If we are going to use a tissue level, we know that this implant must be placed over the crestal bone and maintain the machine surface in the soft tissue. Bone level, in the implant bone level, the abutment has a shape the design of this abutment must be the same of the biological width or the mucosa width. It means that if we don't have enough mucosa width, we need to place the implant crestal. But this implant in subcrestal level must have a conical connection, because it's better, because don't have micro movement. Okay. For example, we have two scenarios. One scenario with 3 millimeters of soft tissue and another scenario with 1.5 millimeters. Where is going to be the implant in each case? If the mucosa thickness is more than 3 millimeters, the implant can be placed at the bone level. Is real true, or we forgot something very important? What the biology say? Where is the cement enamel junction in the neighbor teeth? We need to see what is the environment of this area. What is if we have another tooth very close to the implant, or we have a big space, a dental space. But where is the crestal bone of the neighbor teeth? This distance from the crestal to the enamel, cemented enamel junction is the supracrestal insertion tissue. It means biological width. So if we planning where is going to be the future crown, and we decide where is going to be the zenith of this crown, we need to measure 3 or 4 millimeter depth. It means that in this slide we can see that we don't have enough space for tissue if the implant is placed crestal bone. We need to place the implant deeper. That's why the implant, the subcrestal implant works better than the crestal bone, because in many cases we don't have enough soft tissue. We need to consider that the bone remodelation around the implant, while the osseointegration is created and the bone remodelation, we start to lose bone. But if the implant is subcrestal, the implant doesn't lose bone. In this case, we see a dentulous area with a mucogingival junction very close to the ridge, and we need to know what is the approach of this case. We open the flap. We decide where is the distance between the tooth and implant to implant, and we drill the implant for place the implant more deeper, okay, and place a healing abutment or a cover screw. If we use a cover screw, it's possibly that the bone grow over the cover screw and we need to take out the bone. Okay, what happened if we place the implant deeper and we decide to use a healing abutment a divergent healing abutment. When we screw this divergent abutment, we create a pressure in the crestal bone, in the cortical, and we promote a necrosis. That's why it's better to use a straight and slim healing abutment. Because we don't want to create stress to the cortical bone. We know that the cortical bone hasn't enough blood supply, and we need to protect. And the clot chamber around the healing abutment and the bone promote the new angiogenesis and bone regeneration. In the follow picture, I'm going to show you what is the result after the healing abutment works and how much soft tissue we find. We find a false papilla, and we start, in this moment, we can start with the right hand to create a ideal restoration. If you see that what is going to be the zenith after we place the temporary crown. Here is the X-rays, the evolution of the healing of the bone, okay, changing the from the cover screw to the healing screw, and impression with the emergent individualized emergent profile, choice straight or conical abutment, and we create a perfect space for tissue. In this case, it's very interesting. We place the implant. After the osseointegration, we observe a bone loss, but we continue to create a crown. But what happened? We have a lot of soft tissue over the implant, and the bone start to creep in to regenerate the bone, because we have a lot of space for the mucosa height and the biological width. So this vascularization creates a remineralization of this bone, and we observe in 1 year what happened with the bone. The bone grow over the platform, the implant surface, and it's very good for the bone and for the implant. The bone creeping, it produced by the enough soft tissue over this bone. In this case, this is a new patient, the new case that he had a fracture on the molar. Is a 47, and we place an implant, but no place any graft, bone graft, only APRF membrane. But we close the socket over in the surface to maintain the soft tissue in the original position. We don't create a tension. We don't allow a tension in the healing. and the bone stay in the place, in the original place. The buccal bone stay in this place. It means that to avoid the tension of the healing, we promote the cloud chamber works and start to create bone around the implant. We don't place any graft, and we use only a PRF membrane. So we continue and we restore the crown. 1 year later, 2 years later, we see these X-rays, and the implant don't have enough bone in the cervical area. In this X-rays, in the April 2017, the patient, the bone is in this where is the yellow arrow, and 20 months later, the patient come to the clinic because the crown is loosening. The crown was cemented, and we take out the crown, create a hole, separate the abutment to the crown, cement outside the mouth, and reshape the subcritical contour. "11 months later, the patient come to the clinic, and we observe that the bone grow until the platform. What it mean? The biological width was increased because we change the shape of the abutment and the crown and create more space for tissue. In these two X-rays, we can see that we in 1 year later, when we change the shape of the crown, the bone was stable. But what happened when the crown was loosening? If you see the crown go up, separated from the crestal, creating by accidental more space. That phenomenon attract my attention, and I say, if we create more space for tissue, the bone start to grow because the bone doesn't have a stress of the crown pressure of the abutment, the divergent abutment. Okay. These 4 cases are similar. In the first, this implant was placed subcrestal and the bone go to the platform. In the second, the bone go to the platform, but with a position, a position of bone grow. And in the third, the same. And in the fourth, the bone remodeling down, but only to until the implant platform. Because we create more room for tissue. Okay. So we need to create a crown, an aesthetic crown and biological crown with an emergent profile very precisely, with the distance from the platform to the crown edge at least 4 millimeters. And how we can do this one? Because we don't have a helium abutment with this kind of shape. We need to create and exist a system, a very smart and clever system is a cervical created by two great friends, more than friend, brothers, is Ioannis Vergoulis and George Papalopoulos from Rhodes, Greece. They create these systems to help us to create a helium abutment, individualized helium abutment. In this picture, we observe that what is the distance from the periphery, the implant periphery to the final helium, final emergent profile. Philippe Lobel sent me this beautiful picture of the natural roots at the cervical area, and the cervical has a surgical guide to choose what is the best helium abutment design for each teeth. The intermediate zone is considered from the platform, from the implant platform to the zenith of the crown, where the crown emerged from the gingiva. Okay? This area, we need to design it concave, like Stegman, Amonge explained, and Ernesto Lee explained in their articles. We need to remodeling the abutment or the helium abutment to create more room for tissue. This beautiful system, very smart, we have more than 74 combination of shape, depth, and connection. And I agree that we have two kind of horizontal position, more buccally or more palatal. And this system has a silicone, different silicone with a centered or offset. So they invented this a little beautiful piece to measure where is the platform after the implant is osseointegrated in the bone. We can measure how deep is the implant. In this case, it's 4 millimeters. And we have enough soft tissue to create a beautiful emergent profile and an aesthetic crown. There are many kind of position when we find 3 millimeters or 4 millimeters or 5 millimeters or 6 millimeters of soft tissue. We place the insert that is like an analog, flat, or 1 millimeters depth, or 2 millimeters and 3 millimeters. And if you see, the number is 3 when we rest the different situation. Okay, in this schematic design, we observe the analog is like an implant. We have 3 areas. One is the emergent profile area, then cervical profile, divide in two areas. The blue area is where the epithelium start to grow in number of cells, and the red zone is the plaque zone, where we protect the invasion, the bacteria invasion, when we clean with the toothbrush. Okay. If we decide in the green area to remodeling the abutment, not too divergent, more convex or convergent, we create more space for tissue. Here we see an example. If we find 4 millimeters of soft tissue, 1 millimeters is the width, the silicone width in the bottom, and 3 millimeters is where we developed the emergent profile. See, in this case, the emergent profile of the hyaline abutment don't touch the crestal bone. In this little video, I want to explain what happened if we have four scenarios of mucosa width: 1 millimeter, 2 millimeters, 3 millimeters, and 4 millimeters. But we decide to place the implant bone crestal. What happened with this different situation? In the first, we have only 1 millimeters of soft tissue. It's very common in the lower posterior jaw. When the patient lost two teeth, we find 1 millimeters, 1 millimeters and a half soft tissue. It's not enough to create an emergent profile and a right biological way. So the bone remodelation start to remove bone from the surface of the implant and create a zone exposed of the implant, the treated zone, and this create an inflammatory disease and mucositis, and then perimplantitis. If the implant is going to place in a 2 millimeters of soft tissue, we observe that it's a 1 millimeter remodelation to create a 3 millimeters of biological width. If the implant has a machined color, we don't have any problem. But if you use a total treated implant, we create the same condition of the first, but less. But maybe a mucositis is going to be installed in this area. Okay, and of course we start to see a bone loss. In the third scenario, we have 3 millimeters of mucosa. The implant was bone level. We place the hyaline abutment, and maybe a little remodelation occur, but not problem with the implant. So this bone loss was 0.5 millimeters, because this is the cortical in this area, and maybe is for other reason, maybe drilling, maybe a stress from when we screw the implant in the bone. Okay, the fourth scenario, we have 4 millimeters of soft tissue. We place a healing abutment and we don't have any bone loss. Why? Because we have enough soft tissue to promote the vascularization of the crestal bone. Okay, change the scenario and we have the same mucosa width, 1 millimeters, and we start to place one implant, bone crestal, and the other subcrestal in different depth. Okay, in the first stage, in the first scenario, we place the implant bone level, and we don't have enough soft tissue to create a biological width. And the bone remodeling create an area to promote mucosity and perimplantitis. Okay, and the implant is going to bone loss, of course. The second scenario, we place the implant minus 1 millimeter subcrestal, and we place the healing abutment. The remodelation occur, okay, to create the 3 millimeters of biological width. And the implant has the some part of the surface of the implant exposed to in contact to the mucosa width. And we have bone loss. So, okay. If we place the implant 2 millimeters depth, subcrestal, and we place the healing abutment, the bone remodelation create a biological width, but the sum of the mucosa width and the 2 millimeters subcrestal create the 3 millimeters, and the bone remodeled until the implant platform. Okay, and this area is no bone loss. The last case, 3 millimeters subcrestal, 1 millimeters of mucosa, healing abutment placed, and we observe that after a few weeks, the bone grow over the platform and creeping to the abutment, and the implant was totally protected by the bone. What mean these 8 examples? That if we have an implant and we want to place a crown with 1 millimeter of soft tissue, the bone go deeper to create the biological width, and this crown is going to have a problem with the inflammatory condition, because the treated surface is not good for the soft tissue connection. If the implant was 1 millimeter depth, we have a bone remodelation. If the implant, I repeat, if the implant has a machined collar, we don't have any problem. But if the implant, we choose an implant totally treated, maybe we are going to have problem. The third case and the fourth case as the best, because we create a biological width and the implant don't lose bone. This is what I try to explain. Why we decide to place the implant subcrestal. Why? Because we need to know how much soft tissue have over the crestal bone, and then we decide how deep the implant is going to be. Okay, I'm going to show you simple cases, the immediate implant and immediate loading. We extract the tooth, we measure where is the crestal bone, we place the implant 4 millimeters deeper from the zenith of the gingiva and more palatal. We place the implant, we use an abutment to measure what is the right position of the implant. If we need to change something, this is the right moment to place the implant more deeper or move more to palatal, but this is the moment, not after, when the implant is osseointegrated. When the implant is osseointegrated, we need to invent the solution. Okay, we use a healing abutment, a special healing abutment, individualized healing abutment created by Cervico. Is an offset because the implant was placed palatal, and we fill to create a bulk to grind and create a core to cement a crown just in the border of the gingiva. But first, to promote more vascularization in the clot chamber, we use a PRF membrane or a PRF clot or PRF poncho. Screw the temporary abutment and cement the crown. So from this condition to this condition, very healthy, and the tissue is managed by the healing abutment and the provision. When we decide to take an impression because the tissue are mature, we need to reproduce the shape, the submergent shape of the healing abutment in the transfer. With the same system, with the cervical system, and we place in the area, we see that the transfer go into the gingiva, no create any pressure, and we take an impression. We can see the submergent profile in blue to see that to create a model that for the laboratory, and the laboratory don't need to invent anything, to invent an emergent profile, because we reproduce this emergent profile in the model, and the laboratory by digital or analogic create a crown with an emergent profile like the patient has in the mouth. And the result is this. This is the day 0 of delivery, of the crown delivery. We see a healthy tissue, no pressure, and the result, aesthetic result, is acceptable. Okay, finished my webinar, my lecture. I'm going to say something to take home message. Okay, first of all, the implant position isn't negotiable. The implant has only one position, okay, in 3D position. Second, the mucosa thickness is mandatory. We need to know the characteristic of the mucosa, the phenotype of the mucosa. Third, the implant position 4 millimeter depth from the future zenith of the crown or zenith of the gingiva. The platform switching is beneficial when we place the implant subcrestal. 5. Use smaller diameter of the abutment. We don't sell titanium. We manage the bone and the soft tissue. We need to place a smaller diameter than we usually use. 6, more space for tissue. But zenith decide all. When we determine the zenith of the gingiva or the crown, we know where is going to be the implant. Why? Why we lost bone in this case? Because we don't allow the soft tissue grow under the crown and decrease the vascularization to heal the bone, and the bone going apical to create a space. This area that we see in this picture is the biological width. It's a 4 millimeters, but we didn't consider this situation, and that's why the implant was very superficial and the bone go apical, losing bone around the surface of the implant. All this lecture is about that we need to decrease the rates of the perimplantitis in our office. So, please, follow the light. Follow the umbrella concept. Of course, a teamwork is very important. Ana Luisa Bernotti, my wife and my periodontist, she has the director of the orchestra use. They show me, Alberto, we need soft tissue. Alberto, we need to place the implant more deep. Alberto, we need to create an emergent profile to create more space for tissue. And of course, my assistants, very gently, you see her hand, very gently, she say, Alberto, don't worry about this, pay attention to Ana Luisa, and you know what is the result, don't worry. And pink is my new obsession. I am a prosthodontist, but for me, pink is my new obsession. We need to know how much tissue we have over the bone, no matter if it's a immediate implant in a fresh socket or in a heel bone. Okay? I hope that you enjoy my lecture. Sorry for my English. It's like a Tarzan. But my mother language is Spanish. My second language is Italian. But English must be the 34th language. Okay, I'm very pleased to share this lecture with you, and please stay home and stay safe. We are going to finish this nightmare very soon. if we stay at home and safe. Okay? And thank you for your kind attention. And this is my Facebook and my Instagram. If you want to ask me something or any question, be free to write me, and I'm going to answer your question very soon. Okay? And thank you very much for everybody. Thank you for your more than 1 hour. And thank you for all. Bye-bye.